welcome to all of our attendees, and thank you for joining us today. As well, thanks to those who are going to be viewing the archived edition in the next few weeks. Our apologies to those who are being forced to listen in on the telephone. This morning we didn't have this technical problem, but we seem to this afternoon, and perhaps Heather can solve it. So, just to introduce the consultants, and as you see on the screen, we'll be having two present today, but all four of the consultants are here, so I'd like to introduce them, and they have to crowd into the frame with me so that you can see them. So we have Dr. Gordon Chadwick, who's one of our chiropractic consultants, and I assume they're waving behind my head. We have David Katchen, one of our physical therapy consultants. Dr. Lex Greer, another chiropractic consultant, and Dale Patura, our second physical therapy consultant. So we're going to hear from David and Lex today, and then Gord and Dale will be preparing a webinar which we'll show later this year for more advanced practitioners, those who have treated our clients for years and who have attended 5 or 10 of these sessions. We will send out notices through the association when the next webinar is available. And just to mention, in your daily practice, if you would like to speak to one of our consultants, you can simply call our switchboard and they'll put you through. If it's not the consultant's day at the Workers' Compensation Board, they're going to put you through to a message manager, and then the consultant will call you back on the next day that he's available. All of our consultants are involved in active practice and work part-time for the Workers' Compensation Board, and that's an advantage to us, in that they are still actively practicing and experiencing all the things that you're experiencing in treating our clients. The only disadvantage is that you may have to wait a day or two to hear back until that consultant is back in our office. Just before we start on the slides, I do want to share some news with you. For those of you who are using our online reporting services and our online invoicing, many of you have commented that it would be so much easier if some of those forms would auto-populate, and our IT department wanted me to share with you that they're working on that right now. In fact, it may be working already. It certainly will be in the next week or two, so that there will be the auto-populating feature once the injured worker gives you their claim number, or you have it from the WCB payment voucher or WCB correspondence. So I'm going to move into the slides. We'll be taking questions as we move into the end of the presentation. You'll be able to type those and send them in. So the goals of the webinar are to understand the WCB system, what's available to injured workers, and what is not. We won't linger on that for a long period of time, but providers have said that it's useful for them to know what they can suggest to workers and where they need to be clear that some of the suggestions they're making may not be something that the WCB can help with, but that they need to do in their private lives. We're going to talk a little bit about what is the continuum of care. This is a term we introduced a year or two ago for the previous early intervention program. We'll talk about the guidelines for treatment of soft tissue injury. We'll have some demonstration of online reporting, what our case managers require and what our consultants find very useful in your reports. We'll talk a little bit about those letters that some of you are getting asking you to provide information on your patients so that WCB can do a permanent functional impairment rating for the worker. And we'll talk a little bit about what are the risk factors for chronic disability. No, I'm not. Okay. So just to talk, first of all, about benefits available to injured workers. So going back to the turn of the century, just to set some context for what we have today, injured workers, once they were injured and especially off the job, were required to pay for all of their health care, as did all public patients in the early 1900s. This, of course, would have occurred at a time when they were likely off work and not receiving wages unless they had a generous employer who continued to pay them even though they weren't able to work. Where the employer didn't continue their salary, and we understand few did, the worker had no recourse but to bring a civil suit against the employer. Of course, court cases could be protracted, they could be subject to appeal, so that didn't solve the immediate needs of the worker for financial assistance to support his family or to pay for the health care that he would have needed urgently at that time. Of course, through the court system, the worker won a significant settlement. This could have a major effect upon the employer up to and including bankruptcy. So at the time, the Ontario government asked Chief Justice Meredith to review the issue that was occurring, and Chief Justice Meredith suggested a program that's actually been adopted across many jurisdictions in Canada, the United States, and Europe today. So he basically suggested a no-fault system, which the employers and the workers of that day accepted, but a historic compromise occurred in that employers agreed that they would pay all of the costs of the work injury, including health costs. The workers would not have to contribute towards funds as they do towards employment insurance, etc. And also there would be no use of public funds or the tax base for injured worker rehabilitation and salary replacement. So the employers agreed to pay all the costs of the work injury. In return, they received protection from civil suit, but they also agreed that they would be responsible for work injury only. So to be clear, this is work injury insurance, not work insurance. If I'm unable to work due to a non-injury situation due to general health, I would not apply for workers' compensation benefits. I would apply to a health or disability plan or employment insurance. So Chief Justice Meredith suggested a no-fault system, a collective liability, that payment needed to be secure, that there needed to be some exclusive jurisdiction at the WCBs to avoid the need to appeal to the courts, and a board to administer the provisions of benefits. So to talk about the no-fault system, so he suggested that workers should receive benefits if they're injured in the course of employment, whether the worker or the employer or co-worker, etc., was responsible for the work injury. There was basically no need to determine who was at fault. Once it was determined that a work injury had occurred, the worker would be entitled to receive the benefits of the insurance plans. So in the various jurisdictions, benefits are guided by WCB legislation and policy in that province or state. In the case of Saskatchewan, we're at the current time paying 90% of the worker's net salary, and we don't have a waiting period. This does vary from province to province, but that's where Saskatchewan is right now. Chief Justice Meredith also suggested that employers should be protected by a collective liability function. So employers all pay into an injury fund from which all the costs of the injured workers are paid. So this protects employers against a major accident in their own workplace by spreading the responsibility and the liability, though an individual employer with a very poor injury record or a very good injury record may be surcharged or may receive a rebate. Security of payment, providers will see this go on once a year in the fall each year, where WCB evaluates the monies that are needed to support the workers who are currently in the system, to ensure that there is funding available for any of their needs for the rest of their life. Also at that time, we evaluate current industry to try and project what accidents and accident rates might occur, what costs might accrue over the lives of those workers, and ensure that there is enough money in the injury fund to protect our workers and provide the services that they require. So the employer rates may be adjusted from year to year depending upon the monies available in the injury fund. And there is a legislative requirement for the Saskatchewan Workers' Compensation Board to be fully funded, and so that annual projection and calculation and adjustment is very important. As I mentioned before, Chief Justice Meredith suggested that workers and employers should not need to or have the option of going to the courts in regard to benefits. The Workers' Compensation Board should have exclusive jurisdiction to make decisions about the extent of benefits payable, fitness for work, relationship of a particular condition or symptoms to the work duties. And so the Workers' Compensation Board has 3 levels of appeal available where workers and employers may appeal an issue. Chief Justice Meredith suggested that the system be administered by an independent board. So here in Saskatchewan, we have 5 seats available on our board of directors, and for a number of years we've had 3 board members, 1 recommended by the labor group, 1 recommended by the employer group, with a chairperson appointed by the premier. And in Saskatchewan, maybe a little bit different than some other jurisdictions, they perform not only the administrative role, but they act as 1 level of the appeal. They act as an appeal tribunal as well. So benefits are available to workers in the case of a work injury. So you'll recall the employer is going to pay all of the costs associated with the work injury. So they're responsible for wage replacement for that worker up to a ceiling of $55,000. Their health care costs, vocational services if the worker is restricted from the pre-injury job and is not employer attached, any prosthetics, appliances, etc. that the worker may need. In the more serious injuries, vehicle and home modification may occur. The one-time permanent functional impairment award for the workers that's left with a permanent impairment, and for those workers who have quite a significant impairment, independence allowance to help them with those tasks around their homes and yards that they are no longer able to do as a result of the work injury. What is not funded, because the employer is responsible for the effects of work injury only, is lack of employment once recovery occurs. So if an injured worker is recovered from the effects of the work injury, he has no employer, his WCB benefits will end and he will apply to employment insurance for further benefits as he job searches. Workers who are dissatisfied with the employer or the work or have any industrial relations issues, again, once the worker is recovered from the work injury, their benefits end and they would go back into their workplace and deal with those issues using the means that are available there. Psychosocial issues that impact the ability to return to work. So we sometimes see workers who have recovered from the work injury but now have other barriers to return to work. They may be looking after unwell family members at home, they may have child care issues, etc. Again, we cannot continue to use employer funds to assist with that. The funding ceases and the worker resolves those issues through the workplace or through his own personal means. Non-injury related disabilities, so if I'm unwell but not related to my work, I would of course, once my benefits ended from the Workers' Compensation Board, have to apply to my disability plan or employment insurance. Where the job change also can't be funded unless the worker is permanently restricted from the pre-injury job. So if a very small worker, for example, is found not to have the stature for the job that they're involved in, or the worker wishes to be retrained to a new job, again, that would be handled by the worker or the worker and the employer. As long as they're recovered from the work injury, the benefits from the WCB have to end. So talking about the healthcare aspect of care of injured workers, the WCB has had excellent cooperation from the associations in helping us set standards of care for care of injured workers over and above what your professions require. I think the next slide will show where those documents can be found. So just to touch on some major, some of the main points of what we've arrived at. First of all, the negative response system. So rather than having a chiropractor or a physical therapist submit a form to the Workers' Compensation Board asking if there's a claim, if the claim has been accepted, if the WCB is going to fund that treatment, we have an agreement with the association that the care provider will simply submit the initial assessment report within a day or two and begin treatment. The arrival of that report alerts WCB that this treatment has started, and if for any reason it's not fundable, we've disallowed the claim or we can't pay for that type of treatment, the case manager will send a disallow or a refusal letter to the care provider. So if none arrives, the care provider simply assumes that funding is in place and they continue to provide treatment. Once they've exhausted the first block of treatment, care provider then sends in a progress report indicating either that the worker's been discharged or that he needs ongoing care. If the care provider feels the worker needs ongoing care, and again, no letter from the WCB arrives saying that this will not be funded, the care provider should assume that funding is in place and continue to treat. Where the WCB does eventually send a letter stating that the file is disallowed or the funding for treatment is coming to an end, the care provider is assured that the treatments will be paid for until the date of that letter. And where the file is disallowed, that's simply paid out of an administrative fund. In working with the association, we've also come up with some guidelines and requirements for care providers to provide their expertise to the employer and the injured worker and the WCB in arranging transitional return to work as soon as possible after the injury and helping the worker to move back to their full job duties. And our consultants will talk in detail about this in a few minutes. So here's the site where you can see the documents that we have developed. So the standards of care are on this website, the fee schedules as well. There are billing samples, including the online reporting options, the reporting formats, including online reporting options, and just to encourage people to really take a look at the last two, the online invoicing and the online reporting. Our IT department will soon have these auto-populating to make this a lot easier to use than it has been in the last year or two. And in the case of online reporting, we're paying a fee to those providers each time they do use the online reporting option. That does not include faxing in, it just includes reporting on our site. There's a support package there as well for chiropractors and physical therapists that provides a lot more detail than we can provide today. And in the case of physical therapy clinics, if you take on new employees, the accreditation forms are there to have your therapist accredited with the WCB as well. With the chiropractors, we simply import their billing numbers from Sask Health. With physical therapists, you need to apply for accreditation. So to talk about the continuum of care, the continuum of care basically refers to the three levels of care that are available to injured workers, the primary, the secondary, and the tertiary level. And our goal is simply to ensure that workers move in a timely manner to the level of care that is most appropriate for them, and that the worker is involved in light duty within days of the injury if the employer can possibly accommodate them, and then move as appropriate through more and more vigorous duties until they're back at their full job. I should point out that 90 or 92% of workers require only primary level care and will never progress through assessment team review and secondary and tertiary care. But the continuum of care is basically our effort to ensure that the worker is involved in the right type of care at the right time. So, as I mentioned, only 7 or 8% of workers are going to need the enhanced services of the assessment team reviews and secondary and tertiary treatment, because that is a small number that only experience a delayed recovery. The remainder recover very well at the primary level with the care and the return to work arrangements that you are making. So just some numbers we have from 2011. We don't have 2012 numbers yet. So just over 33,000 claims accepted at the WCB. 21,000 of these are time loss claims, and only, pardon?
No time.
Sorry, 21,000 are no time loss claims, and only a little over 1,400 are off work more than 8 weeks. So I think this illustrates that our care providers, our employers, are doing an excellent job of treating workers, also keeping them at work or getting them back to work in a timely manner, and so few are needing the enhanced services. Just to define a work injury, so work injury is one that occurs at work, sometimes on company property, though it may not be, but as long as the worker is on company business. May also be, work injury may also be less direct. It may arise out of work, and these also are included in WCB coverage. For example, people with asbestos illness, the repetitive strain injuries, that, so these less direct than the immediate acute injury. Work injury is one that requires some medical attention, and it may or may not require time away from work. So we have many no time loss claims that are accepted just for payment of some health benefits, but the worker continues to work and earn a full salary. The WCB has accepted a philosophy of care called the functional rehabilitation model. I think we've heard this called the sports model in other circles, but basically the model that we've adopted is that successful long-term recovery of injured workers is associated with return to function, even in the presence of increasing subjective symptoms where there are no objective signs of harm. So we're looking for what is the worker's function, can we improve that, what does that enable them to do on the work site, what are they restricted from doing, but always stressing to the worker that if their function is improving, they should be assured that they are moving along the recovery pathway, though they still may have subjective complaints. So our legislation requires that where a worker has a work injury, whether he's working or not, the WCB will pay for medically necessary treatment. There are exemptions. For example, farm workers are covered by election only, so if the farmer purchases coverage for the farm worker, they will have that, but it's not a requirement. As well, owners of company may elect or not elect to purchase coverage. So as I mentioned before, it's WCB's responsibility to sponsor treatment to help the injured worker to recover, and our measure of recovery is the pre-injury functional status. We can't assist everybody to return to the condition they were in when they were 20 years old from a functional or an aerobic perspective. What we're looking at is what was their condition before the work injury occurred, and how can we help them to achieve that. In addition, WCB is an insurance company and has a mandate to insure a worker's wage loss. So each worker's wage loss is calculated looking at what he earned in the workplace with a ceiling of $55,000, and that's paid until the worker is functionally able to maintain that wage on their own. So I'm going to turn over to David Katchen, our physical therapy consultant, to deliver the next segment of the presentations.
Good afternoon. I thought I'd talk to you a little bit about functional rehab and primary soft tissue guidelines. Both are programs that are accepted and endorsed by the WCB. The functional rehab model was originally designed to look at injured workers, really from the 6 to 8 week mark on, and the primary soft tissue guidelines has looked to refine treatment within the functional rehab model. The primary soft tissue guidelines has been developed to try to refine treatment up to that 6 week mark. So to start off with, for those of you who aren't archaic like I am, and were around prior to 1995, I thought I'd tell you a little bit about the history behind the functional rehab model. Prior to 1995, it was a pretty dark time in terms of being a care provider and an injured worker in Saskatchewan. One of the things Chris talked about was that 8% of patients who typically are in the system and off work after 8 weeks. At that time, there was no system of triaging patients and moving them to more advanced care. There was one treatment center in the province. There was typically waiting periods of up to 8 to 10 months for those of you who worked at that time. And by the time they entered into these treatment centers, or this treatment center, the caregivers were left with a difficult situation of managing problems that were really associated because of the time frames that they were waiting for treatment. So there was a large task force that was struck in 1994 with all the stakeholders. It spent some time reviewing the evidence that was out there, and it established a system of triage and assessment that basically looked at saying that once that 85 to 90% of patients who moved through primary care were having difficulty, there needed to be a very effective system of timing, assessment, and movement to treatment. And it resulted in a successful and quite an improvement in terms of the number of complex files that existed. We talked about 7 to 8% in 2011. We suspect that it was a lot higher back in pre-1995. Currently, within the country, some form or another of the functional rehab model with tiered treatment exists all over the country. Now, how do I move this? There. Okay. So as the slide says, it focuses on long-term recovery with a focus on function. Chris has already talked about that. So it tries to group decision-making regarding treatment progressions and return-to-work decision-making based on objective findings. Often, the workers who are typically after 6 to 8 weeks, you're going to have to make decisions regarding return-to-work planning in the presence of pain. Now, how does it accomplish this? Well, the review of the evidence at that time said, the best evidence said use soft tissue healing as a guideline in terms of how you're going to deliver treatment. The cornerstone of it all was that you could successfully increase load through tissue and make return-to-work decision-makings in the presence of symptoms if you're using clinical information that was objective impairment findings, objective self-report findings, and objective functional findings that help the practitioners guide and educate the workers back into the workplace. The role of the consultants is quite varied. We're often asked to provide necessary, as the slide says, expertise, advice, and services on matters and projects that may be assigned by the WCB. Dale and I and Lex and Gord are often involved with giving input on a week-to-week basis through regular file reviews. We're often involved in patients that are in the primary system. There's a much more monitored system that doesn't involve us as much in secondary and tertiary through the roles of the clinic managers and the healthcare advisors that help in that process. So we're less involved in the secondary and tertiary files. We're often asked to respond to specific case managers regarding things like the use of appliances, services that aren't delivered typically within the fee schedule. We're often involved in special projects, one of them being the soft tissue guidelines. We were involved in the development and refinement of some quality assurance programs as requested by Chris. But I would have to say the most rewarding piece is when we're invited by the practitioners to become involved in treatment decisions and how they make decisions within the context of the WCB. Sounds like we have some more sound problems.
Yeah, I just talked to our IT department, so I am just working, and it now appears that we can now hear on the computer. If you experience any more difficulties, let me know. But I believe we have it fixed for now, and hopefully it will be fixed for a while. So, yeah.
Okay.
I apologize, everybody, for the...
We must have some gremlins between this morning and this afternoon. We're having quite a few more technical difficulties. So I talked a little bit about another program that's been endorsed by the WCB and that consultants were quite involved in its development of. It's the primary soft tissue guidelines, and a little bit more of a history lesson on how we got here. The functional rehab model really focused on the post 6 to 8 week files, the ones that were quite problematic pre-2004 or 1994. But in response to a request from the Healthcare Advisory Committee, the board, the stakeholders, which included the employee representatives, we were asked to look at what was being delivered at primary from 0 to 6 weeks. The functional rehab program really didn't define treatment during that period of time. In some instances, caregivers were providing treatment at a frequency of once a week, once every 10 days. And some were providing treatment up to a maximum of 2 hours a day, 5 days a week. And the question that came about was, how is that different from many of the comprehensive programs at secondary and tertiary? So in 2008, a committee was struck. I was involved with it, as was Dale Patura and Gord Chadwick. We received some assistance from Richard Barassa, who serves as the rehabilitation consultant for WCB. And we started off by doing a literature review of soft tissue injuries and industrial rehab in the 0 to 6 to 8 week period of time. As you might expect, during that period of time, with that lit search, we didn't find a tremendous amount of information on industrial rehab in the first 6 to 8 weeks. What was there suggested that minimal services needed to be delivered during that period of time, as the majority of industrial rehab should be introduced once the injured worker enters into remodeling phases of tissue healing. We first of all had to establish what were the stages of tissue healing, and the literature was all over the map. Conventionally, we thought of it as 0 to 3 days. Some of the information talked about it as being up to 14 days, with proliferative or subacute starting as early as 3, but starting as late as, or finishing as late as 21 days, with remodeling at 21, starting as late as 40 days. So we needed to develop the guidelines within the context of understanding, well, what are we generally accepting as the stages of tissue healing? And I'm just going to move ahead here. Now, in establishing the soft tissue guidelines, can we go back there? How do we go back?
On the other side?
We also had to understand what would be included in the guidelines. We recognized that the majority of this would be directed at simple soft tissue injuries, those injuries that would be considered reasonably recoverable within a a 6 to 8 week period of time. It excluded surgical patients, ones that we considered going to surgery or who were post-surgical, neurological patients, and obviously fractures, which aren't soft tissue healing, or soft tissue injuries. So we developed 3 stages of treatment during this period of time, from 0 to 20 days, 21 to 40 days, and greater than 40 days, keeping in mind the stages of soft tissue healing. Now, the primary soft tissue guidelines in the first stage, which was defined as 0 to 20 days of biological healing. The evidence said the focus should be on maintenance of generalized function, early transitional return to work, and continued education regarding what would be the expectation of symptoms during this period of time. We recognized that it covered the inflammatory phase of tissue healing and early to end of proliferative healing. It said that support for treatment should invest in return to work planning for transitional duties, and it was expected that full functional testing would not be appropriate during this period of time, and then return to transitional duties could be made off of patient interview, observation within clinical experience, and generalized impairment findings. As mentioned, it encouraged normal activity, which may include walking and swimming, instruction on home-based exercise, and in situations where there was substantial deficits, we felt that it was important to include in-clinic individual regionalized programming to start reestablishing normal patterning of movement. What the evidence didn't support was that full functional conditioning, that fully loaded tissue, was not appropriate until to the earliest phases of remodeling. The group supervised global and functional conditioning prior to 20 days of biological healing from the onset of injury would also not be funded because it wasn't supported. But they did recognize that the occupational intervention of making a communication with the employer, facilitating return to work, was important, and the overall count in terms of treatment would not be included in the total of 10 interventions which were supported during that 0 to 4 week period of time. Now, the expectation, given these guidelines, was that there would be some contact with the employer during the first 4 weeks. In the situation where providers came in contact with injured workers at, say, week 3, the expectation is that treatment would be prorated rather than high-intensity treatment for 1 week to fulfill the 10 visits that were supported with the soft tissue guidelines, as it wasn't really supported in terms of high-intensity treatment. Return to accommodated duties should be at least explored and hopefully arranged, but also that there should be some education regarding what should be expected at this stage of tissue healing and what should be expected as the injured worker advances further. We thought we'd talk a little bit about return to work planning. It starts hopefully within this first 20 days, and certainly will be in full swing hopefully by the time they hit 6 weeks, and again in the normal and complicated soft tissue injury. Provider and worker should have an opportunity to sit down and develop the return to work plan, including what the expected functional limitations on accommodated duties would be. There would be some contact with the employer during the first week of treatment. And as Lex will talk to you in a little bit, the use of the PRTW form has been found to be quite helpful, both from the other caregivers involved, as well as communication with the employer. And the reasoning for this is that it provides a start date, a completion date. It allows, or an anticipated completion date. It allows us to, as practitioners, to be able to include hours per day in the workplace, as well as the restrictions, in a way that is consistent from practitioner to practitioner. Certainly, as we're advancing through the return to work, perhaps not in the first 0 to 20 days, but certainly as you're starting to approach a situation where you're approaching 6 weeks or 6 to 8 weeks where you're advancing tolerances in the workplace, the hope would be that we're going to see a general reduction in frequency of treatment as the stress and load in the workplace replaces the clinically based conditioning that will be applied. So the second phase of tissue healing looked at 21 to 40 days, and really the evidence was quite supportive of intervention that was more physically driven, and more was in line with the remodeling phase of soft tissue healing. It indicated that the majority of intervention has its greatest impact during this period of time. We also identified that the critical period of recovery is typically at 7 weeks. On the WCB case management side, this is a period of time where the file will be scrutinized a little bit more heavily at this point, because what starts to happen is those 7 to 8% outliers become a lot more apparent at that time. So, in response to that, functional testing is funded. Group supervised global and functional conditioning is also included. Ongoing commitment towards return-to-work planning and telephone communication is funded but not counted in the maximum interventions that can be delivered during that period of time. The maximum interventions during that period of time have been recommended at 23 interventions. In most cases, during that period of time, we're expecting that you're starting to get a sense of where the injury is progressing. Has graduated return to work started by this point in time? It should be an early yellow flag if they're approaching that 21 to 40-day period of time on an off-work injured worker where there's no return to work in sight. There should be some referral to assessment if consideration of return to work is not an option at that time for whatever reason. Now, beyond 40 days, we're starting to say, okay, in some instances, the return to work has started, you've needed a little bit of extra time, perhaps the injured worker's gotten out of the gate a little bit later, and we recognize that completion of treatment at a primary level hopefully beyond the horizon. The treatment model supports a decreasing frequency with sort of the peak of care delivered between that 21 and 40-day period of time. Treatment at this time is in place to maintain function while either awaiting for assessment, supporting return-to-work planning. But really, there should be a decision, hopefully by this point, as to where things are going. At this point in time, from greater than 40 days, the WCB supports 16 interventions during this period of time. Now, the expectation at greater than 40 days is that a critical review of where your patient is at this point should be done relative to their position on recovery, if they're an at-work injured worker, or certainly if they're an off-work injured worker. And consideration of an assessment team review should be in the back of your mind if things aren't moving ahead. Now, for many of you today, to review stages of tissue healing is old information, but because so much of what has been developed in terms of the functional rehab model, as well as the soft tissue treatment guidelines, we felt a brief review of it would be prudent. As we talked about, the resources were very different in terms of when the acute fibroblastic and remodeling phase typically occurred, but there are 3 stages of tissue healing. The first one being the acute phase. It's characterized by an unhappy region. There's been some disruption from a soft tissue perspective. We're looking at heat, we're looking at redness, pain, swelling. Clinically, you're going to see spasm, unwillingness to move in response to this. The nature of the pain is chemically based. So typically during this period of time, the functional rehab model that would suggest loading isn't applicable here. It typically lasts 0 to 3 days, but can last as long as 14 days depending on the severity of the injury. And in terms of the recommendations or the soft tissue guidelines, it falls within the first period of time. Subacute phase of tissue healing, it's generally accepted that falls anywhere from as early as 3 days, but as late as 21 days. Typically, the swelling is decreased and is controlled. Pain is changing from a combination of chemical leaning towards more mechanical-based pain, as we're starting to get a scar that's responding to controlled tissue loading. We're starting to improve range of motion and functioning. Supportive return to work at this point is still a part of the model, as long as it's safe loading that's occurring, with the whole underlying theme that we want to create a healthy, well-oriented, stable scar. Again, the second phase of tissue healing falls within this first period of the soft tissue guidelines. Remodeling, that's the period of time that we typically love to treat in, or many of us do. We have a stable scar that's ready and responsive to be realigned and loaded. It responds to progressive loading. We need to be able to understand that the use of objective clinical findings to determine that loading is appropriate or loading hasn't re-entered us back into the inflammatory phase is an ongoing part of treatment and assessment. And it usually occurs greater than 21 days in treatment. And it aligns with the period of between 4 and 8 weeks in the soft tissue guidelines. And as a result, more physical-based programming is introduced during that period of time. You know, I think from the information that I've talked about today, if there's a take-home message, it's really that both of these models of care, the functional rehab model, which historically looked at the post 6 to 8 week files, and the soft tissue guidelines, which looked at refining treatment, were really developed on the premise that we need to look at stages of soft tissue healing. You're going to see the assessment forms are going to lead you through a process of asking you to look at your patient objectively, as well as being aware of the subjective reports, as well as functional information and self-report measures that allow you to come to a conclusion in terms of advancing care and advancing return to work based on this information. And both the functional rehab and the soft tissue models, we feel, encompasses these principles. So I'm going to pass the mic on to Lex, and I'll be in a moment after I talk to you about non-soft tissue injuries. When we were looking at the inclusion, you know, one of the questions that we've received from time to time is what is non-soft tissue, and how is that handled in the soft tissue guidelines? Well, they include fractures, nerve injuries, connective tissue or carpal tunnel syndrome, neuropraxias, vascular injuries like complex regional pain syndrome, as well as obviously post and pre-surgical injuries, injuries that aren't going to follow a simple soft tissue healing timeline. And for those kinds of treatment programs that you'll encounter at the primary level, we encourage you to use a specialized treatment program that will fall outside of these guidelines. Your expertise, as well as what is being guided by the specialists who may or may not be involved, will create a unique treatment program that's different and isn't applicable to the guidelines. And we would encourage you to discuss those types of treatment models when they're going to result in treatment intensity that may come under question, may come into question at a WCB level, and certainly we would like to be involved to help facilitate that. So you can find the soft tissue guidelines on the WCB website at that address. And I realize I'm not out of the picture this early, so I'm going to keep talking for a little bit. Okay, no, you're up now? Yes, you are. Sorry, I'm going to pass it on to Lex.
He just likes being in the limelight so much he doesn't want to stop talking, I think. I'd like to encourage people, if you have some questions, please put them in the chat line or in the individual question area, and we'll respond to them at the end. And we might not answer your question specifically, but we'll try to answer the themes of questions. David talked about the soft tissue guidelines, and I'm going to try and mesh that into what does that mean in terms of how you manage your patients. And most of my time is actually going to be spent on how to fill in that form online. And just a couple of words about file management. First of all, really we're trying to devise a system to allow you the time to sit back and reflect on your patient's individual needs and not kind of think that every patient needs the same kind of treatment management strategy. And it's been said before, but you know, WCB system is really predicated on a time-based strategy, and there are different interventions that are appropriate at the different time levels away from the injury. It's also important to regularly chat with your injured worker about, are they actually doing what you recommended. It's not good enough just to tell them about some exercises, but you need to check back with them to find out if in fact they're doing them. It's always entertaining for me to talk to patients who've come back to see me after 6 months or a year, and they get the, well, no, I didn't do that, but okay, maybe I should have. But I tell people that if everybody did what I told them, I'd be out of business, but I have faith in human nature. So do I need, when I'm looking at patients, I need to think about, can I handle that person just with the resources in my office, or maybe I need the opportunity to mesh with other healthcare providers to give that patient what they need. And also thinking about the clock ticking from the time of the injury, is it time to think about a multidisciplinary assessment, and are there red flags or yellow flags in terms of the patient's behavior patterns that suggest that there may be some other barriers besides physical ones that are leading to a slow recovery time. Again, please use either the consultants or your WCB in terms of getting information that'll help your patient along. And eventually, those patients that are not progressing are going to have an assessment team review, and that assessment team is really looking at suggestions on how we can provide resources to help the patient get better sooner. In terms of reporting, and this leads into the online reporting section I'm going to talk about in a minute, it's really important that you are concise and clear and actually provide a diagnosis. And, broad terms like back pain or sore elbow don't really cut it in terms of providing enough information so that WCB can decide if, in fact, there is a work-related injury and what resources are needed to help the person to get better. And in terms of objective findings, and I'll talk about this again in a minute, but please be specific when you're providing that sort of information. So, my next section is using the website in order to complete forms. And some of you may say, why am I bothering to do this? Well, I can assure you that I know that your reporting strategies are exemplary, but in the main, in terms of actually providing information that WCB can make decisions about the severity of injury, the management strategies that the healthcare provider is actually using in order to move the file along, the reports are not very well done. And the online reporting system is one of the strategies that we're trying to use to help people to get better at that in terms of giving us some information that will actually help the worker get the resources that they need. So the first thing that you need to do in order to be an online reporting is you need to go to the WCB website, www.wcbsas.com, and that will get you this nice screen that looks like that. And then if you're a new user, you need to apply for an account with WCB. And once you get an account with WCB, then you can start reporting online. If you've got a Mac computer, it actually helps you to use the Firefox browser rather than the Safari browser that you get with your Mac computer. And when you sign in, you're going to sign in using, you have to develop a username, and that's my email address, and then a password. And once you've done that, it will actually direct you to a profession-specific series of forms. You can search around on the website to actually find the forms that you need, but what I'm trying to get you to do is actually do this reporting online, and when you do that, it'll actually come up for chiropractors with a initial injury report, a progress discharge report, and David talked earlier about that return to work report, and there it is there. They're all in the same spot. And then forms, there are a series of the reporting forms that you will need to get your patient to fill in to help you to complete the reports. They're found right there on the website. And there's tons of fascinating reading down here as well for chiropractors, physical therapists, as far as how to fill in the various forms and information about the soft tissue guidelines. So when you click on that, I've clicked now onto the initial report form, and it'll come up looking like this, and you need to fill in information about the patient. You will not have initially the claim number, but you can get the person's healthcare number and their date of birth and their employer and their address and so on. And then on this side, this should auto-populate your name and address and so on. Chris assures me it's going to work wonderfully soon. So the first thing you want to fill in is the date of injury and then your date of initial examination. The next thing you need to do, and it's quite important that you do this on your first reporting, is you need to identify all the areas that the patient was injured. And you'll see in this particular example, this person had both a back or low back problem and a shoulder injury. And what we often see on the forms is that there's information about the sort of the most severe thing off the get-go, the person's maybe their back injury, but there's no information at all until a couple of months later saying they also have a work-related shoulder injury. And if there's no paper trail, it's really hard to then provide resources to help a work-related injury that they may have in fact had. If you didn't fill, you need to protect your patients by identifying all their areas of injury. So you'll see on the report a series of drop-down boxes. So I've now identified a back and hip problem. It's a lumbar spine problem. There are a series of drop-down options in each one of these boxes. This is a grade 2 low back injury problem, so loss of range of motion, but normal neurological findings. And then it's a soft tissue injury. And as I said, you need to then identify the next area of injury, and you go through the same process: shoulder, right shoulder, shoulder myofascial, traumatic soft tissue injury. The next section is the mechanism of injury, and you don't have to write a novel here, but you do have to provide enough information to explain the severity of the injury that the person had. And I'm often asked by claims people, how can this series of physical findings get reconciled with this mechanism of injury? And it really helps to protect your patient if you've provided enough information here to actually allow us to make that decision about that. Subjective complaints: he's got a sore low back and a sore right shoulder and restriction of range of motion. Again, you don't have to write a novel, but you do have to identify all the areas of problem that are related to the low back or the work-related injury. Then you need to look at objective findings, and for each area of injury, there need to be objective findings identified, and you do need to put them in quantifiable terms. For instance, in this case, lumbar range of motion was half range, 50% in rotation and lateral flexion, 25% in extension, and so on. There was some paraspinal guarding. The neurological exam was normal. straight leg raise was 60 degrees, creating low back pain. So information like this isn't a lot of writing, but it actually identifies a fair amount of information about the severity of the injury. You do need then to go on to do the same thing for every area of injury, identifying that this person has reduction in range of motion of their shoulder and a bruise on their arm, and pain, weakness with resisted external rotation and internal rotation. So that tells you something. The clinicians will know that can then identify the tissues that are injured in the work-related injury. Did you order any investigations? In this case, an x-ray of the shoulder and of the low back. The next section, let me just go back to that. I'll show you where it is. It's right here. Assessment of recovery status. So you're asked, where are they on the recovery line? 0 meaning no recovery, and 10 meaning back to pre-injury status. And I'm going to say that again because people get this backwards. 0 means bad, 10 means back to the way they were before they got hurt. Doesn't mean back to being 20 years old, to quote Chris, but it does mean back to their condition before that particular work-related injury. So in this case, the person is at 0. The next section is called intensity score. And I've clicked off that it is a 1. Now what does that mean? The intensity score is an identification of how much of a problem you think that this patient is going to be. And the run-of-the-mill patients, your usual patients, are all going to be 0s, but there are a group of patients who, for a variety of reasons, either the severity of the injury or psychosocial issues or labor relation issues at work, are going to be a problem for you to manage and for WCB to find the appropriate funding for their management as well. And it is really helpful if you can identify these clients earlier on rather than later in the game. What is it we're going to do with this patient? I'm going to treat them biomechanically, perhaps use initially some electrotherapeutic equipment to help moderate their pain. At some point, I'm going to have them get back to a return to work, and I'll talk about that a bit more in a minute. And then there are a variety of other things that you would do depending upon the specifics of the particular patient. Frequency of treatment, how many times per week, and I hearken back to David's chat about the various time frames, 1 month, month 2, and month 3. And the evidence that frequent hands-on treatment in that early stages of soft tissue healing where the tissue is quite unstable will in fact likely prolong their healing time. So it's certainly reasonable to be doing things to help them manage their pain, but it is not a good idea to be beating on them vigorously in terms of, well, you would never do that, of course, but in terms of getting them mobilizing or manipulating the joints. So you need to apply the kind of treatment that's appropriate depending upon where they are in the timeline. Expected number of weeks till discharge. And again, there's a drop-down box here, and I checked off the greater than 8 weeks, and you need to explain why, and the answer is, in this fictitious case, multiple previous claims, and he had a recent shoulder rotator cuff repair. we've now come to the first page of the end of the first page, and you can save it, or it's down here, but there's a go on to page 2. And you'll find that if you haven't filled in some of the sections, it's not going to let you go on until you've done so. So it might jump you back up and it'll highlight the one that you've missed. And yes, I know it's frustrating to go back to do that, but it really is important to fill in all the information so the WCB can actually come up with some help for this patient in terms of the appropriate funding. So have I recommended this person be off work? Yes, I have. Am I aware of a previous injury? And I identified that already. Really, you don't need to know a huge amount about it, but it is important to know that if it was last year or 10 years ago, and if they had a long time loss, again, that's useful information to provide. Now, we're coming to the, oh yes, if you have a previous injury, please identify, and in this case, my patient hurt his low back in December 2012. So we have a guy that I said earlier had a previous shoulder repair, and he's now got a low back injury in April 2013, and he had a low back injury in December 2012. So now you see maybe why I clicked off the 1 on the intensity score. And now we're coming to the part where you're actually get paid the big bucks to fill in, and WCB is paying us a lot of money to provide information that's helpful to give us information so we can manage this file, and it's in terms of providing paper scores that should change over time, and also your estimation of their functional ability, which again should change over time. So if you didn't fill in any of this information, you really should be charging only $17 for that report. If you fill in this functional information here, you get to charge another 25 bucks more. And if you fill it in online, you get to charge another $10 or $12 more. So it really is important that you fill in this information here. That should be some indication that WCB thinks it's maybe important. The paper measures that I'm talking about, and if you remember back on the first slide, there's that form section, and you can find these paper measures in it. If the person has a low back injury, that you would use the Roland-Morris questionnaire. If they have a shoulder or upper quadrant injury, they'd use a quick dash. Neck disability for the cervical spine, and lower extremity functional scale for a lower quadrant injury. And please include the raw score in the initial measure, and then all the way through, so that we actually would, what we're looking for when we see multiple reports is changes in these scores here. So initially this guy's Roland-Morris is 22 out of 24, which means he's quite disabled. His initial quick dash is 88 out of 100, and his quick dash work module is 100 out of 100, so he considers himself completely disabled as far as his work tasks go. When you're initially examining this patient, as David identified, you don't need to be doing formalized testing of where their functional ability is, but based on your physical examination and your discussion with the patient about what their job is about, you can come up with some estimates of the kinds of things that you think that they can safely do within their job site. And there's lots of literature to show that the quicker people get back to the job site, the quicker that they actually get better because of the issue of feeling productive to society and so on. So our fictitious patient should only be lifting 5 pounds, pulling 5 pounds, walking less than 15 minutes, standing less than 15 minutes. And one would hope that over time, these functional restrictions should change. If they're not, then you need to step back and reevaluate your management of this patient. Time that the injury may affect the work activity for, and again, there are a series of drop-down boxes, and again, date of return to work. This isn't return to work to full duties, but return to work in some limited capacity, and this is 5 days after the original injury. Have we discussed the return to work plan with the worker? Yes, and with the employer? Yes, and that gets back to those return to work planning forms that are available on the website, and also requires that you actually have some contact with the employer in terms of identifying that there are in fact things that the worker can do on the job site. And employers are getting more sophisticated in terms of providing opportunities for workers to do things on the job site because it's helpful for their bottom line. If they have, the more injuries at work they have and the more time loss they have, their rates are going up. So there is some incentive for them to actually cooperate in terms of getting their worker back to work. Has the return to work been arranged? Yes. If so, what's the date? And then the comment section. This is the place where you can identify any concerns or barriers to recovery that you might have and detail information that would be necessary in terms of yellow flags. And what I actually do in a lot of the forms is I will dictate a letter, which my front office staff can then type, and I just cut and paste that whole letter into the comment section. So in this case, I just identified multiple previous claims, some exaggerated pain behavior, and query whether he's got a rotator cuff strain. So again, save it, and move on to the next page where you electronically sign in, and then you submit that form, which is right over here, to WCB, and then you have an opportunity to print off the form that you can put in the file. Now, if you wish, you can actually get your staff to complete all of the form. You dictate it, they type it, and they just save it, and you can go onto the website and get the form back that's not submitted yet and review it and then submit it. But most people just fill the form in by themselves. So, I think I've covered this already. Return to work patient, the sooner the back to work, the better. See the form on the website. And you can bill for return to work planning, but it does require contact with the employer and a paper trail of estimated functional restrictions. And one would anticipate that if you're filling in a couple of revisions of that return to work plan, that there will be changes in the functional restrictions provided to the employer. There is where you can get that on the website. I think I've covered that already. You can bill for it. And as I said before, really you need to look at other restrictions that you're providing the employer changing. And sometimes there's a discrepancy between what the employer tells WCB and what the worker tells you. And in the majority of cases, when the worker is at full duties and full hours, the WCB claim is going to end. It's okay to monitor them for a couple of visits after that, but I would anticipate the file would close at that point. So you may have a situation where WCB is hearing from the employer that they're doing their full job and they are working their full hours, but the worker's telling you, oh, I can't do this and I can't do that, and it may be that there's a really in the middle somewhere, but it's something that you do need to sort out. Just in terms of what the consultants are looking for, I would anticipate that there is going to be a regular progression of assessment recovery. If it was 3 in the first report, how close is it to 10, or is there a plateau? And is there an explanation of why the progress is so slow? And also, is there a plateau in the paper measures that you're filling in? So that's all I have to say about filling in the reports online, but I would encourage you to do so because it will really help me in terms, it's all about me, in terms of reading your chicken scratch on your reports and actually enabling WCB to receive useful information in terms of providing information that they can use to assist in moving the case along. The other topic that I'm going to talk about a bit is many of you are receiving requests to provide information in terms of physical examination if your patient was injured at work and is going to have a permanent functional impairment. And I just would like to identify a little bit about the kinds of information that we need and also why we need it. The permanent functional impairment ratings are kind of a stylized process, and it's governed by the AMA Guides to Permanent Functional Impairment Rating, Volume 6. And there is a series of information in that identifies how bad the impairment is, and it really is diagnosis-based. And the first thing to understand is the language of impairment. If you're talking about an exacerbation or a recurrence or a flare-up, that means that yes, they got temporarily worse, but they're going to get back to the baseline. An aggravation means that they're never going to get back to whatever their underlying condition baseline was. And this is a long-winded explanation of the same thing. But it really means a permanent worsening in the natural history of the condition. So we all get older. There's a deep statement for you. We all have normal aging changes as we get older, and an aggravation of a injury is such that there is an actual change in the normal natural history of the injury. So as I said, the PFI ratings are based on a diagnosis, and they're based on diagnostic information in terms of what category to put them in. And a higher rating will have more evidence of impairment in terms of reflex changes, measurable variation in limb girth, reduced functional test ability on standardized testing, and so on. But it really comes down to, is there evidence in, for instance, in a disc injury of in 1 level or 2 levels or 3 levels of unilateral problems or bilateral problems? All of those would be reflected in a higher PFI rating. You don't need to worry about all this stuff, but you do need to understand that there's a reason why we're asking for this specific information. So you're going to get a letter that's going to ask for a collection of information. In the old days, what happened is the worker would come to WCB and be examined by one of the doctors at WCB, and then the rating would be provided. And over the past few years, we've moved to actually having you, their primary providers, provide this information, because patients are, quite intimidated by coming to see that nasty WCB doctor, and they're concerned that perhaps the information isn't going to get put in the best light. So it's better that you, their primary provider, provide this information to WCB. in terms of impairment, impairment goes from no impairment to 100% impairment, and it really depends on how much evidence there is of a condition that is not going to get better. So you're asked to do these provided diagnosis. If you think that they've reached a steady state, and then provide information about orthopedic examination, and if they have some limitations at home or at work. And then I'm going to skip quite quickly through this information, but it really is a series of classes of information, classes of severity, and then the information that you provide, each one of these has a number of percentages of impairment, and the information that you provide will move the rating within the class. So you're doing motor strength, grade 0 to grade 5, improper movement pattern impacting function. This stuff should be old hat to you, but you do need to actually provide this information so that it's helpful to actually have an appropriate rating for the patient. Sensation is an dermatomal pattern, and then it's forgotten during activity or all the way down to sensation prevents all activity. Again, in terms of atrophy, for instance, if the person has a disc injury, you're looking for differences in limb girth from one side to the other, so you'd measure 10 and 15 centimeters above and below the medial joint line, and depending upon how much variation there is, that will change the modifier within the class. You are going to be paid a fee to do this, and you can find out that information on the website, and actually, we should be getting some information from the associations in the next few weeks because these fees are changing. And I believe I'm now moving back to David Katchen. Thank you for your undivided attention. I'm sure you found that thrilling.
Check and see if there are any questions. We'll just do a little bit of a...
Okay, maybe we'll wait until...
There's only not a lot yet, so go ahead, Dave.
Okay, so we're almost done. Thanks for hanging in there on a Friday afternoon. We thought that it might be useful to spend a bit of time talking about circumstances where that we commonly see. One example that we'd start with, and I'll sort of set the context, it's what happens in a circumstance where you have a worker who's gone through primary, went on to an assessment team review, then went on to a tertiary treatment program. As an example, we might say they are a post-surgical low back with a herniated disc that went through tertiary treatment program after surgery. They finished the treatment program, and instead of being able to return to their job as a medium industrial level worker, they're working at a light industrial level. This worker is going to end up either at some point along the way or in the future having a PFI done. They may or may not have had one by the time they reach your clinic, or they may have undergone an MAFC, a functional capacity evaluation to define their limitations. So in a situation like that, like this, there's a permanency to their injury. With the exacerbation, if they're the first time into the clinic, one of the things we're going to be asking is it an exacerbation? Has it created a flare-up from their usual baseline status? And the WCB will be supportive of treatment. They'll be supportive of what they describe as episodic supportive treatment. They'll be looking for the treatment to be able to establish movement back into their stable situation with a focus on moving them towards a self-management model, recognizing that it is not inconceivable that at some point along the way they're going to need to be entered back into treatment for some clustered care. There's going to be some circumstances where they will arrive at your office, and they may be a number of years since their treatment and rehab, and you're concerned regarding their functional status may have deteriorated. This may require further assessment. We'd encourage you to contact one of the consultants. It may require a new assessment team review or further assessment with the previous tertiary team to determine if there's functional deficits. But certainly on the treatment side of things, you're going to be admitting them as a primary patient, and the hope is that it will be a clustered form of treatment that would result in stabilization of their presentation and movement back into regular self-management model. Now here's a second entirely different issue that we sometimes see. There's a worker who was injured 2 months ago and is not progressing. You've been treating the worker for 5 weeks. It's very rare that we'll see patients in a daily treatment model, but in this situation we're going to say somebody's been treating daily. And as we talked about earlier, that means they're not following the soft tissue guidelines. Okay? Do you continue to treat daily, or do you move on to an assessment team review? Well, sorry, that's a scenario. It's pretty obvious for most of you who have practiced in the system before. You're at 5 weeks. We've talked a little bit about where internal case management review occurs. It occurs at about a 7-week mark. That's often where we become re-involved in it. The intensity of treatment is supported for treatment from 20 to 40 days. So at this point, we're going to be hoping that you're going to be able to get a good sense of where your worker is going to be, and that you'll be looking at arranging an assessment. I think that's a pretty straightforward one. This is a less straightforward one, and it's one where what is the role of the primary care provider while the patient is attending multidisciplinary treatment? And in this situation, it's probably worthwhile pointing out that when we're talking about the primary care provider, we're talking about the caregiver, more commonly seen with the chiropractors and less commonly so with the physios, because we're all primary access practitioners. We're going to be the first contact with the injured worker when they enter into the system. So what ends up, let's take the scenario where the worker comes in, he's gone through primary treatment. Treatment has probably resulted in the worker not recovering. It's gone on to assessment team review. The information is sent back to you. You recommend a tertiary treatment center. And just like the medical caregiver, you're going to have contact with that worker during the treatment program. We would hope that you're going to have regular communication with the worker during the treatment program. And if the worker is bringing up concerns regarding their treatment experience at tertiary, by all means, communicate that with the treatment center. If it's will help communication lines. I think one of the points that we were talking about earlier is that we want to make sure that the referral and endorsement of the assessment team review would suggest that the treatment center is managing the care at this point, with input from you as the primary care provider. Let's move on to 3 or 4 scenarios just to throw to finish things off. So here's the scenario number 1. Worker has ongoing symptoms, has completed a tertiary treatment program. So you have a patient booked in your office. You're not aware necessarily of all the information that this worker brings with them, but you do know that they finished a tertiary treatment program. They indicate that they're still symptomatic, or they're perhaps having difficulty with symptoms because they're not able to maintain themselves in the workplace. What do you do? We certainly recognize that if it's within the first 90 days after they finish the tertiary treatment program, that the responsibility of the tertiary team is to fulfill the recommendations of the assessment team review, deliver treatment, which typically includes a graduated return to work, and monitor the worker for objective findings as they move through the return to work and make a determination that they're work ready. But it's not inconceivable that along the way after they complete the return to work that they're going to have difficulty. And if you suspect that they're starting to decompensate relative to the level of function, it's really a tertiary treatment issue. We would encourage you to involve the healthcare services team to have the worker re-reviewed at the tertiary treatment center. Certainly, communication and review of the worker a few times is not unreasonable. We've suggested that it's not unreasonable to have two contacts with the worker to facilitate this transition back to assessment at the tertiary team, and certainly that's what we would hope that would be done. So here's a common scenario that we often see. You have a worker that is working at full hours and full duties. Okay, so this is a completely separate situation. You're contacting them at the primary level. They haven't gone to assessment team review. We'll use an example of perhaps a worker who uses his upper extremity a lot and has an impingement syndrome with some tendinitis. So they're progressing along, and you've had 2 cycles of treatment, and you're sitting at 7 weeks of treatment after admission to your care. We want you, as we've kind of alluded to throughout the day, is sometimes when the worker's at work, now whether that's driven by the insurer being reluctant to move ahead with an assessment team review, or the concern that if you move them to assessment, it's going to result in them being removed from the workplace and resulting in a whole host of other issues that will occur. One of the things we want you to think about are the soft tissue guidelines. If you have somebody that's at 7 to 8 weeks, is the injury resolving? Are they back at full work duties? Or if they're at what you think is full work duties, are they really have they arranged for informal accommodation? Or are they not just simply doing the majority of the work that they're doing? Or are they making it through Wednesday and Thursday and having to recover all weekend and before they're ready to go the next day? Try to get an assessment from them, whether it's a self-report or whether you feel that some assessment of functional measures will identify whether they're ready to do or are they work compatible. And as important as anything else, consider rehabilitation relative to the soft tissue guidelines. And if you're sitting at around 7 weeks, have delivered 2 to 3 cycles of treatment, perhaps it's time to request further review in the form of an assessment of a MATR. So scenario number 3, here's an example of somebody who's in primary treatment, and they have 2 problems. They have an SI joint problem that they sustained in the workplace, and they have a knee problem that may look like an internal derangement, perhaps a ligamentous injury that's more than just a grade 1. You start seeing them at week 3. The knee on initial assessment, even at 3 weeks, is painful and swollen. So we're already outside of acute and well into where they should be into fibroblastic, and they've continued to have inflammation. When you go through your report, you're seeing that their assessment of recovery is at 3 out of 10. Not great lower extremity functional scale or Rowland-Morris. They work in a heavy DOT job, and then you start to do your contact with the employer to see if there's accommodated duties, and they're saying, you got to get them up to 50 pounds before I can take them back into the workplace. So you continue to treat, and then you do your first progress note that seems to fall at about week 7, and recurring theme, that's an important period of time when the file is at in terms of biological healing and where it's at a risk for delayed recovery. The swelling's resolved, which we would hope that it would be by this time, but you've still got a sloppy knee. Functionally, you're not getting a lot of change. Back pain's minimally improved. It's mechanical. There's no neurological involvement, but you've still got this medium DOT level as an entry point back into the workplace. Assessment of recovery really hasn't improved a ton. It's gone from 3 to 5, and the lower extremity functional scale and Rowland-Morris isn't fantastic for somebody at 7 weeks recovery. So our questions that we would ask ourselves as consultants looking at the report is you know, is this a file that should continue to be treated, with a call to the WCB to say, okay, I'm going to continue to treat, and we're going to exist out of the timelines at 7 to 8 weeks, and we're going to continue to go for a while. Should you continue to treat with no call as you're confident that it will resolve? Hopefully not. Should you continue to treat but request an MATR? And or should you request advanced diagnostics, and the WCB will arrange the investigations to be expedited? So I've kind of alluded to this along the way, so I won't beat it too much to death. We were hoping that this process will have you look at your subjective findings. Are the numerical pain scale ratings still off the chart? Are they quite high? Are the objective findings, as we talked about, are the quantifiable objective findings changing? What is your recovery of assessment, and are your self-report measures not doing so well? What's the chronicity of the injury, and what stage of the guidelines are you currently in? Do you consider return to work as something that's a reasonable option for this worker at this point in time? And are the resources, and this is a big question, are the resources that you have at your disposal at primary level adequate for the recovery for this patient? So it's not uncommon, and we would encourage you to, if you feel that there are investigations and referral to specialists that need to occur, it's pretty straightforward for the chiropractors. They can make that as a direct referral. The physiotherapists cannot, but they can make a recommendation to the WCB, who will have some communication or facilitate communication to the primary physician to involve them and ask them the question if they feel that advanced diagnostics or an orthopedic assessment needs to occur. We'd encourage you not to delay referral to an assessment team review while the process of evaluating for orthopedics and imaging is occurring. Final case scenario that we'll talk about today, how about the pre-surgical rotator cuff? A patient has already got a surgical date, they're on accommodated duties, they're stable, you're reviewing them for a few cycles, let's say, since the decision on the rotator cuff repair. You've seen them on 2 cycles, you've been seeing them 3 days a week. Each time that you see them, your objective findings indicate that strength is maintained, range of motion is maintained. There's no change in the findings that confirm the rotator cuff tear. You're not anticipating any change in their functional progress, and you suspect that they're maximized functionally from a pre-surgical perspective. We would ask the question, or you'd ask yourself, are you expecting further functional gains to occur? And while we recognize that it's not necessarily appropriate to remove the worker completely from in-clinic care, what will happen if either complete removement or more often reduced frequency, what will happen? Does the worker require 3 times a week in-clinic supervised care, particularly if they're proficient at their regional exercises? And can they be monitored every 7 to 10 days? Now, there's no right answer to this, and every worker's situation is going to be different. But we encourage this kind of thought process to occur in the same way that you would reflect upon your patients when they're going through the system. In another fashion, where you're assessing the findings, assessing whether there's change, and determining whether or not further treatment is being indicated at the frequency that you've been delivering it up to this time. So, in summary, I think what we want to try to do is recognize that the soft tissue guidelines are based on what was available to us as the best evidence. If your patient is more complicated and falls with an injury that doesn't follow the soft tissue guidelines, please let us know. And that's about all I have to say on this point. So, I think that's pretty self-explanatory. The soft tissue guidelines encourage early return to work, regular review with identification of barriers. Please give us as much information as you can on the reports. They're designed to allow you to tell the story of your patient. It certainly helps on file reviews and minimizes our calls to you. And where necessary, refer to assessment team review if you're feeling that treatment isn't realizing a good functional outcome. So at this point, I'll invite Lex to join me and invite you to ask any questions that you might have.
We have one question, and that is, can you download the slides afterwards? And the answer is yes. It'll be ready in a couple of days.
Okay.
I'm given to understand, Monday or Tuesday. There was a comment also that the online system is way too cumbersome. And yes, it's cumbersome, but it's cumbersome because it's designed to have you provide enough information to make a reasonable management decision about how your patient is recovering, and to give WCB enough information to decide which cases require more resources to help the patient to get better. So I hear what you're saying, but and would welcome any suggestions on how you think WCB could make it better, but you need to understand that there is a fair amount of information required to manage this case. Yes, and the self-populating is going to help that a lot.
Significantly.
It's a way to have our clinic information and the patient information saved onto the reporting system. Once you have the claim number, that will happen. And your clinic information should be saved on there when you signed on, actually. If it's not, then talk to the webmaster and they'll sort that out. Any other questions? Well, thank you very much, all.
Bottom one?
Bottom one.
Okay.
Does WCB expect the treatment of repetitive strain to fall in the soft tissue time frame guidelines?
I guess the short answer to that would be yes. We would hope that, unless there's some unusual circumstance, that an RSI is a soft tissue injury. We recognize that the issue that commonly makes that population difficult to treat is that you're managing it while it's limping along inside of the workplace. But to answer your question, we do expect that it will follow the soft tissue guidelines.
There was a question about billing. Did I screw up when I said there's an extra $12 for filling in online? The answer is no, I didn't. It's code 430. If you look at the website, you'll get a listing, and you can get a listing of all of the different billing codes, and that's what the code is for chiropractors. I'm not sure what it is for physical therapists. A question, when a person has a permanent impairment rating and is usually treated at another clinic or in another city, and they come to you on a sort of one-time basis only, you have to fill in the report for that, and the answer is, why wouldn't you? Because you're going to get paid an extra $45 or $52 to do so. But secondly, yes, you do, because it may be that you will provide some information that will help manage this patient better.
The one on the right with the form. Okay. Are we good?
I think we've answered all the questions.
Chris, did you want to?
Make
Thank
a
you.
farewell. So thanks to everyone who stuck it out for a 2-hour webinar. That's excellent. So just to mention that you should please encourage others in your clinic who weren't able to view this version today to take time in the next few weeks or months to take a look at the archived version. That's going to be up for the next year or two because we're hoping that all of our providers will take in a WCB session at least once every couple of years just to refresh on new items. Also, if you'd watch for the advanced webinar that Dale and Gord are preparing for later this year, and we'll announce that through the associations when it's ready for viewing and we have a webinar date. We certainly do appreciate the support and the cooperation we get from the associations. And on this occasion, the Chiropractors Association for granting inside continuing medical education hours and credits for this webinar. So we'll end by thanking our communications department.
I have a question to answer too.
Okay, I won't.
One more question. How do we get CE hours if we're a chiropractor? The answer is we'll send, if you went online, we'll send that list to the association.
And for the chiropractors, the continuing medical education hours are available if you register and listen to the seminar up to and including May 15th. So we'll have a little bit of leeway there. So just to end, thank you to communications. Thank you to our consultants for the work that they did to prepare this webinar and the one that's coming, as well as yourselves for your participation. Bye-bye.
Thank you, everyone. And just to note that I will be processing the recordings, and they will be available online, like Lex said, about Monday, Tuesday, providing technology doesn't have any more gremlins in it. Thank you, everybody.